Good.
Hello and welcome to today's webinar, Attesting for Meaningful Use with T-System EV. Today's webinar will evaluate opportunities for the emergency department to participate in your meaningful use strategy, outline facility strategic considerations, and briefly discuss Stage 2 rules. My name is Amy Johnson, and in just a moment we'll be joined by our presenter. If you have any questions that you would like to submit for the question and answer at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to answer as many as we can as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who was unable to attend. I will distribute the recording of this event to all attendees. Leading our discussion today is Dr. Bob Hitchcock, Vice President and CMIO for the T-System. His responsibilities include developing strategic solutions for T-System EV, clinical sales support, and business case development. In addition to his responsibilities at T-System, he works as an emergency department physician for Manatee Memorial Hospital and Lakewood Ranch Medical Center in Bradenton, Florida. And now to kick off our presentation, here's Dr. Bob.
Thanks, Amy. Good morning, everyone. Thank you for taking the time and joining us today. I'm going to run through a few items specifically related to meaningful use attestation for Stage 1 in the emergency department. The purpose of this presentation is really to assist hospitals who don't have a clear path to getting to Stage 1 in the immediate future, and why that's important for hospitals to consider, and how they may leverage T-System EV to help them meet meaningful use in a much more streamlined and rapid fashion than they may have been considering. So this is really to work through some of those issues and to help raise awareness of the solution that they may already have in their facility in the form of T-System EV and how that can contribute to their success. So we're going to start talking about how the emergency department really participates in meaningful use. And there's really some options about how the ED can participate, but it's important for hospitals to realize they need to make choices now. And the reason for that is there are two things that are going to happen in the next 24 months which are going to have a major impact to hospitals and the meaningful use incentives. The first is that if a hospital is not successful in the fiscal year that starts October 1, 2012 and runs through September 30th, 2013, if they're not successful for their first year by then, they will leave 25% of their incentive money every year thereafter on the table. And for many hospitals, this can be $2, $3, or $4 million in loss. So trying to recover that, or trying to make sure that they get all that money up front means that they need to qualify in their first year of the incentive program before the end of September of next year. So for hospitals that don't have a clear plan, obviously this it should be a major concern for them and maybe an opportunity. In addition, starting in fiscal year 2015, that's October 1, 2014, the government will start to penalize folks who have not been successful in demonstrating meaningful use. Specifically, for those that are successful in 2013, not only will they maximize their incentives, but they'll also avoid penalties for 2015. For those that aren't successful in 2013 but need to leave it until 2014, again, they're going to leave several $1 million on the table, potentially, but they can avoid penalties in 2015 if they're in their first year and they attest by July 1 of 2014, not the end of 2014, but 3 months prior to the end of 2014. The good news is, since the Stage 2 rules have been released, and I'll just briefly touch on those later, what has happened is that for 2014, because hospitals need to adopt new software in that time frame, whether they're in Stage 1 or Stage 2, CMS is allowing hospitals to only attest for 3 months in 2014. It has to be quarters, in other words, October through December, et cetera, but it's only 3 months. So another real caveat here and another real opportunity for hospitals looking to attest in 2013 is that they get full incentives, they avoid payment penalties in 2015, and both 2013 and 2014 will only require 3 months each of attestation. So you get a break and get a much, if you will, quote-unquote, easier approach to meaningful use, in that you don't have to be successful for 365 continuous days in your second year, if 2014 is that second year. What do hospitals need for meaningful use? They need a few basic things. They need certified solutions, and this is combinations of solutions or one mammoth solution, their enterprise system. But they need certified solutions that meet all of the meaningful use measures, even the ones that they don't intend to attest to. For stage 1, there's a combination of both required elements and menu elements. And the hospital can choose to eliminate 5 of those menu elements and not attest to them, but they still do need certified solutions that meet those, even if they're not attesting. For the Medicare program, which is where the bulk of the hospitals are going to be participating and receiving their incentive money, they will actually need to be implemented, not just under contract. The other thing the hospitals need is they need a registration number to play the meaningful use game. As part of registration, they'll actually be going through and putting in the certification numbers of the software solutions they're using, and the tool itself will tell them for sure that they indeed have enough technology in their environment. Now, this is relevant because T-System EV is certified for all meaningful use measures except for 2. We're not certified for reportable lab submission and immunization reporting. So hospitals that are looking to meet meaningful use are going to need to have solutions that are certified for that. The good news is that most enterprise systems are already certified for that. So if you're a Meditech shop or Cerner, Siemens, et cetera, if you're using that in the inpatient environment, chances are you've already got a certified software solution in place. There is one other small piece that's needed, and that's collecting inpatient quality measures, and I'll address that a little bit later. So what is it, after we've got a hospital with an environment that's conducive to them meeting meaningful use and playing the games according to CMS's regulations, what next does the hospital really kind of need to decide? They need to decide an approach to which emergency department patients will be in their denominators. Hospitals, for meaningful use, must count every patient that's discharged from an inpatient status in their denominators. They then have some flexibility in choosing which ED patients they also put in their denominators, and that can either be all emergency department patients or only those that were either admitted or placed in observation, that were, if you will, sick enough to require further care after the emergency department visit that's contiguous with that. The hospital doesn't necessarily need to decide which one of these methods they're going to use when they start collecting data. This is actually reported to CMS during the attestation process after they've been successful and met their thresholds, et cetera. So they don't need to make that decision up front, but making that decision up front will really help them plan and figure out where to focus. And I'll run through why that's important here over the next couple of slides. In those denominators, and part of the reason that discussing early and taking an approach early as to whether they're going to count all ED patients or not is important, is that many of the denominators for meaningful use measures with thresholds, things like recording smoking status on 50% of your patients or recording medications on 80% of your patients, use what's called the unique patient concept. In that denominator, a patient who can be identified uniquely by a, let's say, medical record number, only needs to have an action which qualifies them for meaningful use, like somebody records a home medication. They only need to have that done once, anywhere in the hospital, anytime in the reporting period. So if the patient comes into the ED with an ankle sprain and goes home, comes in with a CHF exacerbation and gets admitted, and then later gets direct admitted from the physician's office, as long as at one point in time during any of those visits someone recorded a single medication on that patient and the hospital are 100% compliant for that patient for the entire reporting period. The reason this is critical is because we can show in our client base and that the success in doing many of these things, such as documenting meds, allergies, problemless smoking status, et cetera, approaches or exceeds 90%. And when you consider that the ED is very efficient in collecting this documentation, does it very, very well, that the inpatient environment doesn't necessarily now have to be as responsible. To say that, what it really means is that implementation and adoption in the inpatient environment tends to be more difficult, and the emergency department can allow the hospital to meet meaningful use while focusing its efforts on the adoption on the inpatient side, as opposed to driving their meaningful use strategies with the observation method or counting mostly their inpatients, where they really need to have full widespread adoption of clinical systems throughout the inpatient environment as opposed to the emergency department. I'll go through several other examples of this in the following few slides, and I do expect some questions on this at the end. The other denominator concept that's important is that the measures for electronic discharge instructions and summary of care provision for meaningful use, they relate to what's called a transition of care. So as opposed to unique patients, they talk about transitions of care. This is important because the transition of care is defined by CMS as a transition of a patient's care environment from one entity to a separate entity. They do not consider the patient going from the ED to the floor a transition of care. The reason this is critical is because for those elements, electronic discharge instructions and summary of care, that have to do with a patient being discharged, if the hospital chooses to use the observation method, in other words, not count any ED discharges, all of those, the only patients that will qualify for those measures come from discharges from the inpatient environment, and the hospital must focus exclusively on their enterprise system to provide that information to the patient. If, however, they choose to use and count all emergency department patients, the number of emergency department discharges vastly overshadows the number of inpatient discharges in almost every facility, and thus the ED can get to meaningful use for these elements strictly, and you don't have to worry about them in the inpatient environment for now. Not meaning to say that you don't want to, but you don't need to from a mathematical perspective. So how can hospitals really leverage the emergency department? In almost every instance, using the all-ED patient methods, the hospital can exceed 80% thresholds out of the emergency department alone, and that's because the vast majority of patient contact happens in the emergency department. I'm going to give a little mathematical equation later, and you'll have some access to slides, and you can go through this if you want to kind of figure out what this looks like in your facility. The ED is also a much easier place to implement technology. You've got a focus group of care providers. You've got a relatively kind of a single workflow. Maybe there's a separate workflow in Fast Track or Pediatrics, but you've got a captive audience and a fairly limited number of workflows. Most hospitals experience significantly better adoption of technology in the emergency department than the inpatient environment, and that's really regardless of technology. For instance, Leapfrog, an independent organization, has really studied and worked with hospitals to get CPOE adoption. They found that CPOE, once implemented in the emergency department, is adopted in excess of 90% of the time, whereas on the floors, it's less than 40% of the time. And that's really independent of the technology that's there. So the ED is a great place to leverage technology. It's also generally less expensive to implement technology in a single isolated area than it is across an enterprise. And speaking specifically of T-System EV, like I said, we've demonstrated that our users, even before meaningful use existed, were exceeding 90% or more for most of the clinical measures, particularly the important ones, meds, allergies, problem list, vital signs, etc. So how T-System EV can help impact strategies specifically, we'll talk briefly about CPOE. Most hospitals have a significant concern about being able to reach CPOE even though it's only at a 30% threshold. The denominator for CPOE is all patients who have medications in their medical record. The numerator is 30% of those unique patients must have one medication entered through CPOE. CPOE for stage 1 is not just CPOE as we consider it, which is medications ordered for administration during the emergency department visit or their inpatient stay, but it's also prescriptions that are written, not through e-prescribing, but are written the way they are today in T-System EV, which is through circles and backslashes with a printed prescription. That does count as CPOE. And like I said, the emergency department adoption of CPOE is usually much better than the floors. Because the requirement for CPOE in stage 1 also pretty much puts the onus on physicians to enter orders, it's very difficult to get community physicians doing inpatient care to use a system solely for the purpose of entering orders. In every facility that we've been involved with, the facility can reach 30% of CPOE using the emergency department alone. And this is because, again, we're talking about unique patients and that the vast majority of patients come through the emergency department. In general, 30% can be attained using either the all-ED patients method or the observation method. So regardless of whether or not you count the patients that were discharged from the ED in your denominators, most hospitals, if not all, can get to CPOE 30% thresholds using an ED CPOE solution. Clinical documentation, again, our experience is that in our client base, 90% to nearly 100% compliance with these measures. It's a great way for a hospital to know and rest assured that the important clinical things, meds, allergies, problems, vital signs, et cetera, are being captured in their emergency department. Knowing that, the hospitals can focus on any potential gaps in the inpatient environment or where they're having failures of adoption on the inpatient environment. And very often, they can focus on those for business reasons, not for meaningful use reasons. That is to say that they've got meaningful use in their pocket because of the work that the folks are doing in the emergency department and the systems that they're using. And they're focusing more on what's happening on the inpatient floors because they need to, either for business operations or for patient care, not because they need to get to a certain threshold. That's taken care of already. The ED also is a place where, particularly for best of breeds like T-System EV, interoperability is the mainstay really of our existence. We are at the leading edge, if you will, of interoperability, and enterprise vendors are now being forced under these meaningful use programs to start accepting discrete data. This becomes even more true in stage 2, so that the ED will become connected to other environments by force, if not by choice, and that the technology the things that are being leveraged on technology vendors in the background are changing the game, and you'll find that it's easier to connect those systems, and it will be easier to continue to have best of breed solutions in the areas that you need them to drive your business operations in the hospital. So as of November 30th, 2011, that was after the first real year of meaningful use. T-System was used in 42 facilities to meet meaningful use. We were the only best of breed to make the top 10, and as a matter of fact, the next closest vendor solution had, I believe, 7 sites that they used. So there's a big gap between us and all other best of breed solutions used for meaningful use. I think that, again, that was due to the fact that many of our facilities were already exceeding their threshold measures before meaningful use was even defined. This was literally as simple as flipping a switch, doing a little reconciliation with data in the background, and reporting. Sorry, it was 4, was the next closest vendor. In discussing then, how the ED fits into this, the next logical question becomes, okay, well, do we roll out an enterprise solution in our ED, or do we keep our best-of-breed solution? The argument for enterprise solutions are that most of them are what we call complete EHRs. There's no functional gaps. They are certified for everything, and theoretically can meet meaningful use in every measure. You don't have to put other systems in. The issue is, though, that although they're certified for each measure, user adoption is painstakingly low and difficult to attain, and takes an extended period of time to both build content as well as get users to adopt so that you can get to these thresholds. So although well positioned on paper to meet meaningful use, we are finding that facilities are struggling in many cases to get the user adoption to a level that's sufficient. Thus, they're looking at the ED and T-System EV to help drive their meaningful use. As we discussed, kind of single workflow versus multiple environments on the inpatient side makes it easier to focus on the emergency department from a meaningful use perspective, as well as cost. So now I'm going to transition into actual strategies and what you can use, either leverage with your planning committees or use as information to take back to your executives and say, hey, we may have a solution here for you to get us to meaningful use faster. First, figure out what impact the ED actually makes to your organization. I'll go through that math in a second. Meaningful use is purely mathematics. CMS doesn't care how you got to your thresholds, as long as you played the game correctly and you played by their rules. The important thing is that your numbers reflect that you exceeded those thresholds, met or exceeded. Then break some of the features and the meaningful use measures into functional and solution groups. That makes it very easy to figure out kind of how you're going to attack things. There's groups of elements for clinical documentation, and this is part of a much larger strategic talk. But those are things like meds, allergies, problem lists, smoking status, vital signs, etc. CPOE should be addressed as a standalone issue because it generally does affect the entire organization in some way, different than purely collecting clinical documentation elements. Then there's demographic and health information management type issues, such as electronic provision of health records and discharge instructions and collecting demographics. Many of these can be handled through a registration system as well as the HIM department and can be handled as a group for looking for strategies of how those can be attained. There's then laboratory and public reporting issues, interoperability. Most of the interoperability, actually all the interoperability that's required for stage 1 is all attempts to connect systems together or attempts to get information downstream, but you don't have to be successful. So much of the interoperability falls on the IT department to try and connect systems, but again, they don't need to make those connections happen. There's then security. On the vendor side, we're already certified for certain security elements. On the hospital side, the IT shop has to do a security review of their systems. And then one large group called quality measures, which we'll talk about in a minute. When we look at the all-ED patients method, here's the math. What you want to look at for your facility is take all of your ED patients and then figure out what patients were direct admitted that never passed through your emergency department. In most cases, ED admissions make up between 40 and 60% of total admissions, with the remainders coming from either direct admissions from outside offices or from post-op, et cetera. You want to compare what the percentage of your total ED patients is to that volume. And in general, most facilities will find that that number is somewhere around 88 to 94%. That is to say that 88 to 94% of unique patients will have documentation in your EDIS for your facility. That makes it pretty easy to get to 80% thresholds out of your ED alone and help you focus on the again, issues that you may be having for other reasons. This is to say that most hospitals could meet meaningful use with T-System EV and a little bit of inpatient clinical quality measure data. You cannot, unfortunately, meet meaningful use with T-System EV solely because hospitals are required to report on all clinical quality measures, many of which are inpatient measures only and have to do with what happened when the patient was discharged from the hospital. Thankfully, most enterprise systems, like I said, are already certified, and they're already gathering that information, or somebody is inputting that information or can input that information. So the work to do to get to meaningful use is really focus on collecting those other quality measures. Two of the quality measures are ED specific, and our system will provide the numerator and denominators for those. You get the numerator and denominators for the remaining quality measures from your enterprise system. You add them together, literally add them together, and when you're attesting for meaningful use, you put those numbers, those added numerators, added denominators together in the attestation web page through CMS or their attestation tool, and you're done. It's that simple. So you can drive all other elements of meaningful use, you can drive out of T-System EV should you should you choose to do that, using this all ED patients method and counting all your emergency department patients if this calculation is in excess of 80% in your facility. And again, it almost exclusively will be. What if it's not? Well, the impact really is only to 3 measures, and those are the 80% threshold measures. documenting medications, documenting allergies, and documenting problems. Chances are this is already being done in your enterprise solution, at least to some extent. The highest threshold under the 80%, the next highest is 50%. I've not encountered a facility where the ED was of sufficiently low volume and the inpatient of sufficiently high volume that they could not get to 50%, counting all of their emergency department patients. Again, still need that quality measure data, regardless of what solution is used or whether you use the observation method or the all-ED patient method. You do need inpatient quality measured data from a certified system. This is a look at an actual hospital, and it shows that they can meet or exceed all thresholds using T-System EV alone, and this is really counting just the emergency department patients. And assuming that nothing happens on the inpatient environment, you can see that the thresholds are all met or exceeded. And again, these are actual numbers from an existing client. You'll see that their CPOE is their success rate is about 80%. Now, I do want to say that they're not putting 20% of the orders in CPOE. It's that CMS has defined CPOE in such a way that if a patient comes to the emergency department who is on a medication at home but doesn't get a medication in the ED or doesn't go home with a medication prescription, that's considered a failure. Kind of silly, but that's the ED workflow. It happens occasionally, and so your numbers will reflect that. In addition, nurses that put in verbal orders or may transcribe a written order from time to time, those orders don't count for meaningful use either. So we do know that in the emergency department, verbal orders are acceptable in certain circumstances, and if you do have nurses enter those as verbal orders, per CMS, those don't qualify. But you can see the remainder under that second column in gross contribution, how well folks really did at this site, and this is fairly consistent across the board. In this case, you'll see demographics at 100%. That's because demographics is being gathered in their registration system and put in the ADT feed over to T-System where it's picked up by us. So the work is actually being done by registrars, which is probably rightfully where it should be. It's gathering things such as the patient's birth date, their preferred language, their race, their ethnicity, and typically that's done in a hospital system. If it's reported to us electronically, then we can help you figure that numerator and denominator. If you choose to use the observation method, what does the math look like? The math looks a little bit different, and what you're doing is you're taking your total inpatient volume and figuring out what % of that actually comes from your emergency department, whether being admitted as an inpatient or being placed in observation, whether that's observation in your emergency department or observation outside of the emergency department. If that is greater than 80%, then we have the same statement we made before, that you can meet meaningful use with T-System and a little bit of inpatient quality measure data from your enterprise system. However, most sites are not going to reach 80%. In most cases, it's about 40 to 60%, as I stated earlier. So with the exception of the one or two 50% measures, the hospital can meet almost all the other measures, the threshold measures, and can still meet all the other measures except for, like we discussed earlier, providing summary of care to the downstream providers and providing electronic discharge instructions, because those will not apply because there are no discharges from the ED in this calculation. So those elements do need to come from your enterprise system. So choosing the observation method for the hospital does imply that the strategy has to focus specifically on high threshold items, as well as items that can't be accomplished except in the inpatient environment, electronic discharge instructions, and providing summaries of care. With this method, I mean, if you choose the observation method, and many hospitals are, what they're using T-System EV and all the hard work of the emergency department care providers, they're using the outcome of those to help reduce any risk of failure on the inpatient side, or to really bolster their numbers and allow them to figure out what they need to focus on. So again, just a comment about electronic discharge instructions. The reason that that's important is that important to consider is that it needs to be provided at the time of discharge. That can't be managed as a later business operation or have the patient come, request them at a later time. When they're discharged, if they ask for their discharge instructions electronically, they need to be provided them at that time. So what do we do about those clinical quality measures? Well, there's a few different ways to accomplish this. Like I said, we've got ED-specific quality measures that have to do with ED throughput. We have inpatient-only quality measures, and there are a couple that overlap, like giving thrombolytics for acute strokes. It can happen in either environment, and information can be gathered. The good news is for stage 1 that accuracy in reporting these numbers is not in question. You can report completely inaccurate numbers, but you're required to report what your certified systems tell you. So the fact that you may not be able to fully reconcile this information is okay. I will tell you that stage 2 addresses this, makes it a whole lot easier for both vendors and hospitals to get to the right numbers by ensuring that not only are vendors accurate, but there are ways to share that information seamlessly so that you don't have to have a manual reconciliation process or re-entering data in between there. So what are the strategies hospitals can look at for stage 1? Well, one is, like I said before, they can report the ED measures from T-System EV and the others from their HIS. All you do is add the numerators and denominators together and report those over to CMS. You will likely underreport some of those crossover stroke measures that can be met both in the ED and the inpatient environment, but that's okay. You could collect the ED time milestones, which are related to the 2 ED measures in your enterprise system. Again, you will likely underreport some of those crossover measures, but again, that's okay. And in many cases, the enterprise system is actually collecting those time milestones. The time milestones required for the ED1 and ED2 are the time the decision was made to admit the patient, the time the patient was arrived, and the time the patient actually left the emergency department. You'll also need to know the diagnosis of the patient because they do kind of factor out whether psychiatric patients are a separate group in that reporting, and you'll need to know if the patient was placed in observation. The enterprise system almost always knows the arrival time, and they almost always know the time the patient left the emergency department in some way, shape, or fashion, the diagnosis, and the actual disposition. If they know the decision time as well, the time the decision was made to admit, then the enterprise system can actually calculate all this, and you don't have to worry about reconciling or adding numerators and denominators. You could collect all data in one system. The data doesn't have to be gathered in real time for clinical quality measures. Someone could key in all the data related to clinical quality measures. This is probably the most accurate way to do it. The fact is you're actually probably already gathering information on all these quality measures anyways for other public reporting and other programs such as IPPS, OPPS, Hospital Compare, et cetera. So that is an absolutely valid approach provided you have a certified system for that person to enter that information into. The last approach is to take an automated reconciliation approach and have data taken out of both systems, put into another tool, such as a business intelligence or analytics tool, combined, and then you're reporting from that system. It's much more onerous, it's far more accurate, and it allows you to have a repository for reporting, not just for clinical quality measures, but for a lot other business and patient care objectives as well. Let's take a look quickly at what best practice looks like from using the emergency department to help driving meaningful use. So the strategy is, first of all, let's figure out how we're going to get the reportable labs and the immunization reporting covered from a certified solution perspective. If you're using a certified EHR right now as a complete EHR in your enterprise environment, you've got this taken care of. If not, we'll have to help you figure out a way to fill those gaps in. It's either upgrading your enterprise system or going to find a solution that does this that's inexpensive and focuses on these 2 elements. Make sure you've got our 3.0 or our 4.0 version. Those are both certified for stage 1 criteria. Get your registration number. do the math, figure out which approach really works best for you. If the all-ED patients method gets you above 80%, I would suggest strongly that you go down that path, knowing that you can always use the observation method if you choose when you attest, but that you can pretty much guarantee your success using that all-ED patients method. All right, here's what you do as a facility. Use T-System EV CPOE and turn on the alerting. What you will get, this will get you the CPOE measure, your drug formulary, which is a menu measure, and drug-drug allergy interaction checking. You're covering 3 meaningful use measures by using CPOE and making sure that you have the alerts turned on. Then record medications and allergies. Typically, this is done very well in the emergency department. This gets you a medication list, allergy list, and gets you the med reconciliation. The reason for this is that the way CMS defines med reconciliation for meaningful use is at the beginning of the visit, not at the end of the visit. So recording home medications in T-System EV gets you 2 measures, med list and med reconciliation, which is one of your 5 menu items, and recording allergies gets your allergy list. The next is to either document a past history element and or a diagnosis on the patient, a clinical impression. This gets you a problem list. Nearly every patient leaves the emergency department with a clinical impression. Thus, you will be near 100% just by doing what you're doing today. Record smoking status. This is widely done by clinicians today, primarily because on the physician side, they need to get points, if you will, toward past family and social history so that they can bill at optimum levels. Smoking is one of the easiest ways to do that, both in our system and one of the easier questions to ask patients, and it often comes up. So we find that smoking status is pretty widely and pretty universally documented. So far, I don't think we're asking people to do anything different than they are today unless they're not using CPOE. You need to turn on our clinical decision support rules. They were intentionally designed for stage 1 so that they're not going to fire and become terribly intrusive to providers, but by merely turning them on, you've met that measure. Document discharge instructions for the patient. That gets you a menu measure called patient education. If they ask for electronic discharge instructions, give it to them. This means that you'll need to set up a way to either write their discharge instructions to a CD or to a thumb drive, or we have the option of delivering those electronic discharge instructions to the hospital's email server in an encrypted fashion, should you choose to disseminate them that way. The most important thing here, I think, is don't ask. Don't ask the patients if they want their discharge instructions electronically, and you're not required to give them right now. Stage 2 addresses this, by the way, by adding a patient portal requirement, so it'll kind of happen in an automatic fashion, if you will. Try to send syndromic surveillance. This is a public reporting element that gets you the one required public reporting menu element. You do not have to be successful at this. Our system will produce the file that's necessary to send, and you can contact your public health department, ask them for some basic information, which is essentially where do we try and send this thing, and see if you can make it happen. Chances are you won't be able to. That's a limitation of technology that exists today and is well recognized. Have demographic information collected in your ADT system, in your registration system, and sent over to T-System in the ADT message. Most facilities are doing this today. At one point during the 90 days, run one patient list, and that's a report that's shipped with T-System EV. You basically go in and you can run one list about, let's say every patient over the age of 65 with an acute myocardial infarction who got aspirin. Once you've done that, you've met that measure. Save that report, put it in your file should you ever be audited in the future and you're done. And then report your clinical quality measures. By doing these things, and you can see none of them are a huge impact, and many of them are small impacts to the IT shop and don't even touch clinicians. You've actually met almost all of meaningful use by doing these few things. What's left? What else has to be accomplished by an organization, provided they've done everything that we talked about on the last screen? Any patient that asks for a full electronic copy of their medical record must be provided one. We recommend, again, that you don't tell patients that. It can be done with T-System, but we highly recommend that it's actually done through your medical records department. They've been providing medical records for a long time. They understand what HIPAA tracking and what the requirements are for doing that. If there are any charges, you can do that if applicable. And again, the technology solution behind it could be as simple as putting a DVD burner or a CD burner down there, or opening up a USB port so they can copy it to a thumb drive. Most enterprise medical record systems are certified to do this for meaningful use as well. And then get those quality measures from the inpatient environment somehow reconciled and reported out. So there's very little that's really left to do outside of T-System. And again, even the medical records you could do from T-System and meet that measure, but you probably don't want to do that. You could if necessary, if you couldn't come up with a workflow or a solution down in your HIM department that would do that. So T-System does also support data extraction for meaningful use. If you do want to incorporate data from T-System into a business intelligence tool or into a vendor solution tool, such as McKesson and Siemens have individual tools for meaningful use, we have data extraction packages that can get our data out and help you reconcile those. Contact your client manager if you're interested in doing those. I've got one slide on Stage 2 rules. Stage 2 rules were released. We'll have several webinars about Stage 2 here in the coming weeks, but just to give you an idea, as you're thinking about what's going to happen in the next 2 years, you do need to be aware that some things will impact you from Stage 2 rules, even if you're not at Stage 2 yet. The first is that after October 1st, 2014, all hospitals will need to have newly certified software against the most recent criteria, even if they're in Stage 1. The good news is, though, for 2014, if you've already attested for meaningful use, you only need to attest for 1 3-month period, as I discussed before. If it's your first year in 2014, it's still the same 90 days, whereas if it's not your first year, it's 1 quarter. So you don't have to have it out of the gate starting October 1. You can take a little break and upgrade your software, let's say, around Christmas time when nobody else is really doing anything, and then a test starting in January or in April. The clinical impact of Stage 2, and I did not list all the measures here, but the clinical impact for the Stage 2 rules is essentially the following. CPOE has been changed to count all medication orders, all lab orders, and all radiology orders. This essentially means that CPOE must be adopted throughout the enterprise, both in the ED as well as in the inpatient environment. As we discussed before, the ED is relatively simple and straightforward compared to the inpatient environment, but hospitals will have to look at getting CPOE rolled out widely. An electronic med administration record with barcoding or some other automated assistive technology will need to exist in at least one area in the hospital. It's a relatively low threshold, but 10% of medications administered in the hospital must be tracked through an EMR solution with barcoding. And e-prescribing, it's a menu item for Stage 2. There are several other menu items that are a lot easier to attain, but if the hospital chooses to do that, they'll need to implement an e-prescribing solution in one area. We would recommend probably the emergency department if you're going to do that. The threshold is low. It's only 10% of medications written at discharge need to be done through an e-prescribing solution. Again, that's an optional menu item. There are others that are going to be easier to attain for the facility. So the clinical impact really is use EMR, and everybody's pretty much got to get on board with CPOE. That should not truly affect the emergency department greatly. The impact, though, from Stage 2 is really to the IT departments. For those of you on the call who are clinical analysts or who work primarily in the IT department, the expectation here is really there's a lot of lifting that your department's going to need to do. A patient portal needs to be implemented for the hospital. Patient information needs to be made available to patients, discharge instructions, health records, access to information within 36 hours of the discharge. And it needs to be done in such a way that really a patient portal is about the only way you can do it. Hospitals will have to implement system interoperability to share clinical information, medications, allergies, and problem list, as well as demographic information at a minimum in a document called a CDA. You will have to do that and connect, and at least 10% of patient visits need to have that information sent electronically between systems. that goes toward transitions of care, and we're not talking specifically about ED to inpatient, but the fact is all vendors are going to be developing solutions basically to the same specifications. So connecting the ED and the inpatient environment really shouldn't be any significant additive work, but interoperability will become a true reality in stage 2 and a requirement. No longer can you just try and attest. Reporting labs, immunizations, and syndromic surveillance, that will need to be successful and ongoing. Unless you have no receiving facility, then you'll get an exemption from that. So the IT shops will be busy. The clinicians in the ED probably won't feel any significant impact from stage 2, but the docs on the floor certainly will from a CPOE perspective. That's what I've got. We can open this up to questions at this point. If anybody has any, and if I completely and totally lost you, I apologize. But we can, again, a recording of this will be available for you to review, and I can take additional, questions either through email, which is there, bhitchcock@tsystem.com, or you can look at other, authoritative types of reviews for some of this information. So the first question is if you test for stage 1, for year 1 of stage 1 in 2013, you would still have a full year reporting for stage 1 in 2014. And actually, no, that's not true. It would have been, but the stage 2 rules address this because the market has to adopt software in 2014, and the vendors have to develop and certify it. 2014 is only 1 quarter of reporting, so either October, November, December, January through March, April through June, or July through September. So that is a great break, and I think everyone has applauded that, from vendors to the market in general. Question number 2. We were told that we could report zeros for the clinical quality measures. Is this not true? Yes and no. It's not specifically not allowed by CMS. What CMS requires you to do is to report clinical quality measure results that come from your certified solutions. You're not allowed to go try and change those results or optimize them by doing some manual abstraction and coming up with a different number. If your systems report 0 to you, yes, you report 0. During the attestation process for meaningful use, not only will you have to enter this information, you'll need to attest that you believe as a facility that these are relatively accurate calculations, and relatively accurately reflect your environment. If you can say that with zeros as clinical quality measures, then yes, you can report them. I think that there is a risk under audit if you're a large facility where you clearly would have patients with strokes and VTEs, thromboembolism, et cetera, and you're reporting pure zeros on these. It may not be looked upon favorably, but the fact is it's not strictly prohibited. So we recommend that hospitals try and get inpatient quality measure information out of their inpatient system, and you can add those numerators and denominators. There's an FAQ from CMS that allows you to do that. Don't all hospitals need to be on 2014 criteria, October 1, 2013? That is true, and if I said 2014, I'm sorry. It is October 1, 2013 in preparation for the 2014 fiscal year. So I'll go back and make sure that that typo is not in there. This is what happens when you talk fiscal year versus calendar year. Yes, October 1, 2013 for the 2014 fiscal year, hospitals need to adopt. So that's the reason that for the 2014 fiscal year, you don't have a full year's worth of reporting because the market and vendors couldn't support getting everyone upgraded in the next 13 months. So I apologize if I misspoke on that one. It's something that I do not uncommonly, and I'll have to get a new tattoo on my forearm or something to remind me of that in the future. I think that's all the questions that we currently have in front of me. If there's anybody who has a last-minute question, please feel free to put it up on the screen, or you can go ahead and email me, and I'll get back to you personally with an answer to those questions. And for the questions that I did just answer, if you would like any kind of stage 2 final rule language or something that speaks to this, go ahead and let me know. And like I said, we'll be having some fairly in-depth reviews of Stage 2 here in the coming weeks that'll go through not only the measures, but the changes to the program, such as the one-quarter reporting requirement for the 2014 fiscal year. All right, time to wake up, everybody. I'm sorry if I put you to sleep. I know this subject becomes a little difficult, but I hope you all took away from this that the ED is an extremely important area in the hospital from a meaningful use perspective. You guys have a lot of power in the ED to help drive meaningful use success. Many hospitals have underestimated the impact their ED can have on their success, and in some cases haven't even looked at the ED. And when they realize that they currently have a system, if you've got 3.0 in place, you currently have a certified system that could be exceeding your thresholds, that's an incredible sigh of relief for many hospitals as they try and figure out how can I maximize my incentive, minimize the work on my staff, both clinical and technology staff, and avoid payment adjustments in the future. Thanks, everybody. Appreciate it. Have a great day. Thanks for everything that you do.